Session. To the organizers for this opportunity, I will be talking about the post-operative complications of penetrating keratoplasty. Although we have shifted to lamellar keratoplasty for all the vision-related things, but when it comes to ocular saving, mostly we are dependent on penetrating keratoplasty, and that is the reason precisely why we need to know this procedure in details. So these complications can be divided into three parts: those occurring early in first 7 days, intermediate in first 3 months, and late beyond that. So in early phases of keratoplasty, we need to think of some problems related to wound, epithelium, AC status, etc. And we'll see few of them in pictorial manner. Exposed suture knot, although this is a case of old graft, but we can see the exposed knot here. And we can see something like this on the very first day after surgery. And this knot doesn't only make the patient symptomatic, but it also acts as a nidus for infection. So whenever we are tying the suture, we need to follow the proper protocol of suture tying. We need to consider the knot size, make it as small as possible. If 3-1 is larger, then go for 3-1-1 tying pattern. And cut the suture, not neither very close to the knot, not very far off, just the adequate size. And whenever we are trying to rotate it, we should rotate it into the stroma, not just beneath the epithelium. Otherwise, when the corneal edema will go down, probably the knot will get exposed. Then, if we have something like this in first post-op, then we can try rotating it even under slit lamp view. But if that is not successful, we need to go to OT and replace the suture. Similarly, loose and tight suture. We can see on the left side there is one loose suture. On the right side, we can see the tight suture. And loose suture is not going to serve any purpose other than being a source of infection, vascularization, etc. And tight suture is going to induce astigmatism. So in these cases, what we should do first, while tying the suture, we should adjust the proper suture tension, consider the graft edema, consider the tissue edema, even the scleral bed also we should consider. And when we are finishing the case, we should always try to form the AC with BSS, preferably if the iris is not very flaccid. Otherwise, the AC will appear to be well formed, but once the air will get absorbed, the sutures will appear loose. Although this problem is lesser with nylon suture. So if we have something like this in early post-operative phase, we can replace the suture. But if we have it in the later phase, like beyond 3 months and so, we can simply remove the suture, because beyond 3 months, most of the tissue adhesion has already occurred. Sutural infiltration. We need to differentiate between inflammatory or immune-mediated infiltrates and the infective infiltrates. Immune-mediated infiltrates, as we can see it here, they are multiple, mostly seen on host side. They are not associated with epithelial defect, and they respond to steroid. Iris incarceration, again something like this we can very well see in cases of therapeutic keratoplasty or those cases with adherent leukoma. And we need to rule out the active leak with Siddle's test. And something which I always follow, whenever I'm trying to pass suture in these cases, I lift the wound edge and then only I pass the suture, so that I'm assured that the iris is not there with the suture. This was one case of adherent leukoma, and iris was completely plastered to the cornea, and we tried saving it, but there were multiple cuts. On the very first day, we saw that there were multiple iris pigment clumps here. But on the oblique view of the slit lamp, we could see the iris well behind, and the AC was quiet. So we just continued the patient with the standard treatment, and the patient responded very well. So this is something we should keep in mind, that whether it is frank iris tissue or just the pigments there. AC status. If AC is flat and there is an active leak, we need to take the patient immediately to OT and reform the AC. But if AC is shallower or moderate depth and there is a minimal leak, we have time. We can take liberty, we can put BCL, wait for 24 hours. If the AC is formed in 24 hours, we can, wait and put the BCL, continue the BCL for another 2 days, and then try removing it. But if the AC is not formed, even with that, then better to take the patient for resuturing. Epithelium management. This is particularly more important in cases where the primary pathology is important, like in cases with compromised ocular surface. Like the upper one, this was a case of silicone oil-induced keratopathy, and the silicone oil was still there in the posterior segment. It was practically oozing out. So obviously the epithelial problem is going to be there, the healing problem is going to be there. Similarly, this was a case of Sjogren syndrome. So whenever we have a primary pathology like this, we should go for good tissue, preferably not with an epithelial defect. And We need to stain this graft regularly to ascertain that the epithelial healing is going on or not. What I practically follow, if the epithelial defect has not healed by 1 week, I go for PCL application. And if it had not healed by 2 weeks, then I go for tarsorrhaphy. That is my pattern. IOP management, if we have a low IOP with shallow AC, always first rule out any leak. But if there is no leak, then we should rule out choroidal detachment, retinal detachment, or ciliary shutdown because of uveitis. If we have a high IOP with shallow AC, we need to think of pupillary block glaucoma or something which is like pushing the lens iris diaphragm forward. So we need to manage accordingly. Graft infection, this was one case of therapeutic keratoplasty. We did the graft here, and on the very next day, we got a picture like this. It came out to be pseudomonas. We did a repeat grafting. Somehow we saved the eye, but the patient lost the vision. So in these cases, we have to make sure, especially when we are going for repeat grafting, we have to make sure that we are using cornea from a safer source. Like we need to rule out the primary infection at that point. And we need to consider the color and everything about the storage media. Antimicrobials, as per the culture sensitivity report, if it is available, and withheld corticosteroid if possible, at least in the early period, because here the aim is not visual gain. At times, we need to differentiate between infection and inflammation, like this was a very large size therapeutic graft, and on the second post-operative day, we got a picture like this. In the middle picture, we can say we had this white granular appearance. So granularity is something like which goes more in favor of inflammatory exudate. So we went ahead and continued the steroid, and this patient responded well with the steroid. AC inflammation, this was again a case of adherent leucoma, and the pupil was not dilating, and we did a triple procedure, but the initial 10 days was very bad. The graft was not at all getting cleared. We gave a bolus of steroid. Finally, the graft got clear, and then we saw that there is a lenticular matter, lens matter behind the IOL. We aspirated the lens matter, and finally the graft got clear, sure. Late post-operative complication, the primary is graft rejection. All the more very important in cases of high-risk cases, we need to make the patient aware of RSVP. Can be epithelial, stromal, or endothelial. Epithelial rejection mostly responds to topical steroid, but stromal and endothelial, we can go for IV methylprednisolone with IV DEXA or IV DEXA along with systemic and topical steroids. Post-keratoplastic glaucoma, more common in aphakic pre-existing glaucoma, triple procedure, vitreous loss, intense inflammation. These cases, they do not respond very well to medication, especially if the angle structures are already collapsed. There is a peripheral anterior synechia. So we need to go for TRAPS, GDD, or cyclodestructive procedure. This was one case of tectonic keratoplasty where we had initial melt here at 12 o'clock. So we went ahead and did a scleral patch here. But we saw another leak here, but when we explored this, we found that it was just a minimal leak. We put amniotic membrane grafting, we tightly closed it with tenons and conjunctiva, and ultimately it did well. This is ultimately graft failure. Thank you so much. Yeah.
Thank you. Very nice collection of cases and essential lecture in this era of lamellar keratoplasty. We should not forget penetrating. Do you consider mixed suturing, like 8 sutures of
continuous?
Yeah, because it takes care of most of the problems.
Yes, sir. Yeah. In therapeutic cases, I always go for interrupted, but otherwise, optical I go, sir. I do it.
That helps in
that helps a lot.
Gives a balance of both.
Yes, sir, definitely.
Thank you. Thank you for attending the